Good afternoon, everyone, and welcome to the Hartford Institute for Geriatric Nursing webinar series, in which we address issues which are pertinent to our aging population and of particular concern in this time. I'm Tara Cortes, the Executive Director of the Hartford Institute for Geriatric Nursing and a professor here at NYU Rory Meyers College of Nursing. I'm delighted to introduce you today to our moderator, who's a wonderful friend and colleague of mine, Dr. Anderson Taurus. Born in Ponce, Puerto Rico, and raised in the South Bronx, Dr. Torres is currently the president of RAIN Total Care, Inc. RAIN services include 20 programs, of which are 13 full-service senior centers, home-delivered meals, home care services, serving homebound persons of all ages, integrated care coordination, housing, case management, advocacy, support groups for the elderly and their caregivers, as well as Alzheimer's initiatives, transportation, and intergenerational programs. That's quite a portfolio, Anderson. Dr. Torres secured his master's in social work from the Silberman School of Social Work at Hunter College and his doctorate in behavioral psychology with a focus on environmental design for Latinos and Alzheimer's disease. He's been in the field of healthcare for over 30 years, focusing on the areas of mental health, geriatric care, academia, government, and administration. Dr. Torres serves on the New York State Public Health and Health Planning Council. He provides lectures on the topic of Alzheimer's disease and related disparities. Dr. Torres is well known to his constituents in the Bronx. He is active politically. He impacts policy and legislation at both the state level and the national level. And he is, as I said before, a wonderful friend, and I'm delighted to call him a friend as well as a colleague. Dr. Torres.
Thank you, Tara. Good afternoon. Thank you for that kind introduction. Welcome, everyone. I'm Dr. Anderson Taurus, President and CEO of RAIN Total Care, a not-for-profit organization really focusing on addressing the social determinants of health in our community. I'm going to be acting as your moderator for today's discussion of addressing health disparities to support aging in place. It's happening to all of us right now as we speak and we tune in. I'd like to introduce you to each of our distinguished panelists. You've already been introduced to Dr. Tara Cortes, Executive Director of the Hartford Institute for Geriatric Nursing and professor at NYU Rory Meyers College of Nursing, who will be speaking today on building healthier communities with health literacy. Our next panelist, Dr. Tina Sadarangani, is also at NYU Rory Meyers College of Nursing as an assistant professor. She specializes in the advancement of the health of vulnerable older adults by leveraging the strengths of community-based adult day health centers, care centers to target health disparities. Dr. Sadarangani will be speaking today on using advocacy to address food insecurity and social isolation. And lastly, we have Dr. Sarah Szanton, who is an endowed professor for health equity and social justice, as well as the director for the Center for Innovative Care in Aging at Johns Hopkins School of Nursing. Dr. Szanton will be speaking today on addressing health disparities by focusing on function. It's very important that as we prepare to listen to our distinguished guests, that we please list our questions on the Q&A box, not in the chat. You could say hello to everyone in the chat, but your questions, your key questions on the Q&A. If we were in another setting a year ago, I would say, put your phones on vibrate, okay? And the restroom will be located here and there. Just remember to be conscious of sound during our presentation. Again, the Q&A is very important, and we're going to be concluding at 4 o'clock. So please, here we have our distinguished panelists.
I think we start with me, is that right?
Yes. And as Dr. Tara Cortes prepares, I had the pleasure of working on a project with her all about health literacy in the older population. Here we
And
go.
that actually is the project that I'm going to be talking about today, the one that we did in the Bronx. This study was funded by the GWEP grant from the Health Resources and Services Administration. We also had funding from the New York Community Trust, and also we had funding from the Accelerating Interprofessional Community-Based Practice and Education Initiative at University of Minnesota. A little bit of background on this. The Bronx Health Corps was developed through partnerships, and I really believe that to impact community health, you really have to build partnerships that include community-based organizations. So we at the Hartford Institute for Geriatric Nursing joined hands with two community-based organizations in the Bronx. Our primary one was RAIN, which Dr. Torres, where Dr. Torres is the president and CEO, and the other organization was JASA. So included in our population was 16 senior centers. The goals of the project were to increase health literacy of older adults through education on healthy living and chronic disease management, and also to develop and educate a group of volunteers to provide community-based teaching for older adults. So you can see there were really two pieces to this, increasing health literacy, but also to have a group of community-based volunteers, because we do believe that getting your volunteers, getting teaching from the community enables it to be the most culturally sensitive teaching that really resonates with the people. And also we would hope to have some more sustainability by teaching people within the community to be educators. So why am I moving forward here? So some of the issues in the Bronx. Well, the Bronx is the poorest urban county in the United States. Hard to believe in the middle of New York City, part of New York City, we have the poorest urban county. It's ranked the lowest in health outcomes in all of New York State. 30% of the population report their health is poor or fair. 29% are physically inactive. And the rates of drug overdose deaths among adults aged 65 to 85 have more than doubled. What we did was we first held focus groups with older adults in several of the senior centers at RAIN to determine what did they think their educational needs were. You know, we come in as the healthcare providers, and when I worked in another organization in East Harlem, people there used to say, oh, you people come down from the mountain and think you can tell us what to do. Well, they're right. We can't tell them what to do. We need to get their input in terms of planning on addressing their needs. So here's just two of the things that they said. He said, please, nothing on diabetes. That's all we hear about from the doctors. No one talks to us about sexuality because we think we're too old, but we actually do have very many issues. So they get diabetes education. It's an area where diabetes is the most prevalent chronic disease. So they do get a lot of diabetes education, and they don't want to hear it anymore. But it's interesting on the sexuality, because it really is true. Very few physicians are comfortable addressing sexuality in older adults, and they do have issues. So the Hartford Institute developed materials on 10 topics, and we included an instructor's manual, handouts, and PowerPoints. And all of these are downloadable from our website, hign.org. The topics we narrowed in on were in three areas, or three buckets, if you wish. The first one, healthy living, covered stress management, nutrition, sexuality, and exercise. The second bucket, chronic disease management, addressed not diabetes, but the other most prevalent diseases in the Bronx, and that was heart disease, asthma, and Alzheimer's disease and related dementias. And then we added two specialty or educational sessions, one on oral health and one on opioid use and misuse. So we recruited our volunteers through the senior center. So many of our volunteers were older adults who were just so happy to be able to do this and really anxious to learn. We also recruited volunteers through colleges. RAIN has a wonderful internship program, particularly for social work and for nursing. So we used some of those interns and trained them because many of them were from that community. We ended up training over 3 years. We trained 175 volunteers. These volunteers educated over 2,000 unique older adults with a total attendance of over 5,000. So some of the adults attended more than one of those sessions, one of those topics. So all in all, we had 5,000 people sitting in the audiences. We did pre and post tests to determine knowledge changes. And then we sent surveys out 90 days after teaching to determine the behavioral changes. So let's look first at some of the changes in knowledge. We examined these using a statistical method of Fisher's exact test. In the ADRD, we had significant gains on the knowledge in 8 out of the 10 items. One of these was, were you aware that a medical examination needed to determine an ADRD diagnosis? Pre-test, only 50% thought that you needed a medical exam. Post-test, 82% thought you needed a medical exam. On asthma, we had significant gains on 6 of 10 items. One was on identification of asthma symptoms, and these are really pretty dramatic. On the pre-test, only 25% could identify their asthma symptoms, and on the post-test, 95% could. Awareness of asthma triggers, which is so important. On the pre-test, only 5% thought they could identify them. On the post-test, 95% said they could identify them. On oral health, we had significant gains in 8 out of 10 responses. One of those responses was the question of, we said tooth loss is not a normal part of aging. And 39% thought it was a normal part of aging. And then afterwards, 63% realized that this should not, is not normal, that you really, good dental health, good oral health prevents the loss of teeth. In the healthy living workshop, we had significant gains on 9 of 15 items. Safe sex practices, 63% on the pre-test and 90% on the post-test. That's a very, very important area for older adults, particularly with the prevalence of sexually transmitted diseases now in older adults. The health benefits of exercise, 60% knew the benefits before the content, 89% on the post-test. Aware of such services as Meals on Wheels and food stamps, because we tried to address social determinants, particularly food, the need for food, and 75% on the pre-test were aware of Meals on Wheels and food stamps, 92% on the post-test. And we know here in New York that the majority of people who are eligible for food stamps just don't know about them, and they're not collecting food stamps. Healthy Heart, there was a 3-module course, and our quantitative data on the knowledge check found no statistical significant increases on either the scale or level item. So we really need to review the course for the content in it, but also the appropriateness of the pre and post test. Qualitative data, which I'll talk about in a moment, showed behavioral changes with very positive results. So let's look at the behavioral changes now. Oral health, 95% reported making positive changes in their oral health routine. 47% said they started flossing. 35% said they were now removing their dentures at night. They never knew they needed to remove their dentures. They just didn't take them out and clean them. They just kept them in their mouths. Healthy living, 83% reported being engaged in healthier behaviors after the classes. Some of those behaviors were eating more fruits and vegetables. 56% said they were eating more, and 53% said they increased their physical behavior. ADRD, 85%, this is, I think, is so important, 85% reported greater understanding of behaviors associated with dementia. 40% said they shared the information with their families and friends, and 21% said they talked to their doctor about dementia. And we know that so many older people, couples usually, where one of the a husband or wife, or even a mother, a father, a sister, brother has behavioral changes with dementia, and people just don't understand. I think they've gotten so nasty. This helped them to understand what are those behaviors as they are associated with Alzheimer's disease and dementia. In asthma, 85% reported positive behavioral changes. Healthy heart, here's where we didn't have anything on the pre-post test, but when we asked behavioral changes, 95% of them reported positive behavioral changes. Those included things like 50% said they were choosing lower salt options, 54% said they were now reading food labels, 50% said they increased physical activity. And we did do, we looked at blood pressures at 3 months after the education, and there were no significant changes in blood pressure at 3 months. We weren't really surprised because we know this needs more in-depth study of exercise, nutrition, and also medication compliance over a longer period of time. Some of the anecdotal comments from participants were, I eat more vegetables and I avoid fried foods. I include more physical activity in my everyday life. I learned breathing techniques to help me relax. I have more energy and I feel stronger. I keep my home trigger-free and it helps me feel better. And this one I thought was really profound. You saved my life. And I said, what do you mean we saved your life? Well, she said, I never knew how to talk to my doctor about how I felt when I had an asthma attack. But you helped me to know what to say to the doctor. And I was on the wrong medication. So our next steps are to expand our volunteer corps to other areas with focus on cultural and geographical diversity. We're looking for funding in rural New York State because we think this would be very different as how we operationalize the program in a rural area where people can't come as easily to a senior center. We want to add new topics such as telehealth, social determinants of health, and social isolation. We want to continue to solidify community-based partners to ensure sustainability. And we also want to engage primary care providers to refer patients to educational programs in the community. Because one of the things I found in visiting primary care offices was physicians would say to me, oh, Tara, we don't need this because we educate everybody, we teach everybody. But we know in the short period of time that the patients are with their physician, it's impossible to give them everything that they need to be educated, number one. And number two, they're only with that physician a short period of time. And then they go out in the community where they live. And they don't see the physician again for maybe 6 months, maybe a year. It's important to have that education reinforced in the community. Thank you very much. And now we'll move on to Dr. Sadarangani.
As we get ready to listen to our next panelists, thank you, folks, for beginning to post your questions on the Q&A. I reminded folks in the chat, so keep those questions coming on the Q&A box. Thank you so much.
Well, hello, everyone, and thank you so much for having me. It's always a pleasure, and thanks to Hartford for arranging this. Today, I'm going to be talking a little bit about my work, which, as Dr. Torres mentioned, is in adult day programs. And I'll be talking specifically about how we can use advocacy to address food insecurity and social isolation in older adults. Bear with me. So I'm sure I'm addressing a group of people who understand how fundamental to health nutrition is and realize that even as Dr. Cortes pointed out, we cannot address disparities in health without a focus on nutrition, at least in part. But what I want to share today is a little bit more about how we cannot view nutrition separately from another problem that we know plagues older adults, which is isolation. And we know that isolation has been pronounced, especially in our post-pandemic world. So what I hope you'll get out of today's presentation is recognition of the fact that community-based programs like the ones Dr. Torres runs are lifelines truly that address both of these social determinants, that both address isolation and nutrition. And that as clinicians, researchers, caregivers, community members, whoever is on this call, we really have to advocate in favor of these programs because they do so much to address multiple components of health. A little bit about me. My training is as a primary care nurse practitioner specializing in the health of older adults. My research has concentrated on the health of older immigrant populations, specifically focusing on how we can leverage the strengths of community-based organizations like senior centers, like adult day programs, to address disparities. And really my goal is to advocate for expanding services and accessibility to adult day programs because they are vital community resources. So I always say that while I have no conflict of interest, I do have a vested interest in the health of vulnerable populations and the community programs that support them. My passion for nutritional research in the area of nutrition came out of a project actually that was completely unrelated to nutrition. I was asked by the California Association of Adult Day Services to serve as an evaluator for a special project they had worked on called the Community-Based Health Home Project. And what they did was they took their most vulnerable group, they identified those with the most complex health and social needs within their adult day centers, and partnered them with a nurse navigator whose job it was to leave the four walls of the center, help them with whether it was at a doctor's appointment, if they went to the ER, to make a home visit, and sort of work with them throughout whatever transitions of care they were having. The program, which served a very diverse group, and this pie chart over here is meant to show you just how the diversity within our population. The languages spoken here, just for less than half of our participants had English as a preferred language. We had Spanish speakers, Vietnamese speakers, Chinese speakers, Russian speakers, Korean speakers, Farsi speakers, and others. But the main goal of the project, as I said, was to pair people with a nurse navigator to reduce adverse healthcare utilization, such as hospital visits and emergency department visits. And what we found after this program was tremendously successful in reducing those things, that having the support of a nurse at all points of care was critical and met wonderful outcomes, particularly because the nurses got to know these individuals so well by observing them in their adult day centers and then following them within other settings. But then we realized that there was a subgroup of people who, despite all these intensive sort of supports they were receiving, continued to have emergency department visits and hospitalizations. And as we delved deeper into that population, what we realized was that one of the key predictors of that was their nutritional risk status. And what I learned as a sort of emerging scholar in this area, it really shed light on the fact that nutrition is a lens for so much more. And I'll show you what I mean by that. We went in and we broke down our population according to different racial groups. And we used this thing called the Determine checklist. Now, I'd like to just say something about nutritional screening in adult day programs. We don't screen older adults, despite their risk, for malnutrition. Older Americans Act programs like senior centers or Meals on Wheels, they have to screen their participants, but adult day programs are governed by the Child and Adult Care Food Program, which is a completely different entity all of itself. And they have the same requirements for children as adults. They don't have special requirements for older adults, which is predominantly who adult daycare programs serve. And so our study was really the first to do a full-blown screening on them and understand what it was that was driving their risk. And one of the things that we noticed, if you look at this, so the Determine checklist looks at everything from their chronic diseases, their access to fruits and vegetables, how many meals they eat, their oral health, their economic hardship, reduced social contact, whether they're on multiple medications, involuntary weight loss or gain. It looks at their needing assistance with self-care and their age. So I want to point out that, as I said, nutrition screening is a lens into so much more than just someone's nutritional status. And what we found in this is that this was a population that was at very high risk of malnutrition, but that certain groups, certain risk factors were much more pronounced in certain racial groups than others. And so I'll just point you to something where here you have, for example, involuntary loss or gain was predominant in 24.5% of our population. But among Blacks in our population, that was affected 48.5% of people. And the other thing I'd like to point out is that 8% of our population overall reported eating less than 2 meals a day. Among Blacks, that was 20.6%. So you can see there are substantial differences depending on racial groups. If you look at reduced social contact, 39% of the overall population reports reduced social contact, but that was elevated both in among whites and in our Asian American participants as well. So this is just to draw your attention to the fact that there are risk factors for malnutrition that differ according to racial groups, and that has to inform how we address these issues. I also want to point out the fact that in that this previous slide, we noticed that some of these older adults were eating less than 2 meals a day. Well, one of those meals is coming from their center. So without that meal, which it potentially is a lifeline for these individuals, that serves as a real problem. And we need to be thinking about that in the wake of a post-pandemic world when many of these centers have been shuttered for almost over a year now. I want to make the point that the Supplemental Nutrition Assistance Program, which is a USDA program, is not enough. It is not enough to simply give people a little bit of money and benefits for food. We found that SNAP recipients met, several studies have pointed this out now. I allude to one here where that SNAP recipients continue to remain food insecure. And that this is particularly problematic in diverse communities. We found that SNAP benefits received by older adults are particularly insufficient in certain groups. So females, Hispanics, African Americans, people who are facing high healthcare costs. For them, SNAP may not be enough. Reduced or fixed income is another vulnerable group, as well as those with low social support. So we have found that in the United States overall, 50% of households that received SNAP benefits in 2016 continue to report consistent food insecurity, and they continue to rely on emergency food systems. So that's something I want to point out, and why I continue to make this link, that it's just not simply enough to say, here's some food, here's some groceries, here's some money for food. It's so much more than that. We need to be doing a lot more to address food insecurity, particularly in older adults. Why is that? We know that older adults are nutritionally vulnerable. They have different nutritional requirements than other groups. They need distinct foods that are to manage certain chronic conditions. We see high rates of kidney disease, heart disease, diabetes in these groups. And oftentimes, these individuals are prescribed foods low in sodium, sugar, phosphorus, or high in potassium. But the problem is that many of those types of foods are not available through the food programs. As I already mentioned, the adult day programs, we don't even screen for nutrition really in these programs. So they're served a standard meal. It's unclear if they're meeting their protein requirements or anything else. There are also significant associations between depression and food insecurity. So we know that they're related. And so it's not just enough to address that. And I think the main takeaway point from all of this is that we cannot really begin to address food insecurity and nutritional risk in older adults without advocating for community-based services, because they are so essential in addressing this problem. What we see, and goes back to that link between nutritional risk and social support, we know that their poor mental and emotional health stems from living alone and having reduced social support. That can also result in a loss of interest in cooking or eating, and ultimately reduce food intake. Somebody who's homebound with an illness, who's functionally impaired, can also, these are themselves are risk factors for reduced access to food, to having a poor appetite, and difficulty independently preparing meals. So many interventions are out there that say, oh, let's just hand someone a bag of groceries at their primary care visit, but it's simply not enough in this population that's so vulnerable. Without a social support network, which many older adults lack, really you cannot help a homebound person. They need assistance with retrieving and preparing meals. And I'll show you some findings from my own work that really validate that. We especially, have to worry about those who may just have enough income to not qualify for home delivered meals or groceries, but remain food insecure. I will say that for SNAP benefits, anybody with more than $3,053 in their bank account is ineligible for SNAP. So think about it, having $3,000 in your bank account, you have to cover rent, you have to cover several other expenses. Many people don't have enough for food and yet remain ineligible for these programs. So we know that all of these circumstances that many of our older adults who are vulnerable face can further increase their feelings of loneliness, social isolation, depression, and unwellness. That's why we need it's more than just a meal. I want to point out some of the findings from my own work. This was from that CDHH study I alluded to earlier, the community-based health home. They wrote, an adult day center nurse said, we had one participant that's on the community-based health home. We worked really hard to get her CalFresh. Well, it came back that she was only getting $15 a month. This is somebody that's in a wheelchair, homebound, and can't get out of the house. She has no money, doesn't have family that supports her, and she gets an extra $15 a month in CalFresh. As of right now, we're going above and beyond. We go pick up her food at the food bank for her and bring it to her. And then we have this other issue where we assume that people who live with their families have supports there, but that's not always the case. This quote actually came from a woman who was a Chinese immigrant, late life immigrant who came to this country in her 60s. A nurse said that she was talking to her. She lives with more than 10 people in her family and said, they don't want me to eat together within the dining room. So she's dining alone in a house full of people. What we know is that loneliness and social isolation can limit older adults' access to food, particularly if they have no way of getting food, as I said, without the assistance of companions or family or social supports. And social eating, certainly in my own family, is a social activity for many. It is hard to eat alone. We know from studies that eating with others is associated with less food insecurity, better nutrition. And so company can make a big difference. And it can lead to, without not having company, can lead to reduced pleasure with food and eating. Loneliness and social isolation also really lead to social depression, which can lead to poor eating habits and ultimately food insecurity. It's like a circle. So just to let you know where we are now, before the coronavirus pandemic, nearly 9.7 million seniors were threatened by hunger. We know that number had increased during the course of the pandemic. 1 in 4 seniors lives alone, 1 in 4 feels lonely. And we know that hunger and isolation can affect anyone with limited mobility. Financial strain really makes all of this much worse. So you have now older people, such as those in my study, who not only have poor functional status, perhaps are cognitively impaired. And now you have 7.4 million seniors who also are living below the poverty line. That's an income of $240 a week or less. And many of those people are living alone. Those who live in poverty are nearly twice as likely to have limitations in their ability to live independently. You can see how among different racial and ethnic groups during the course of the pandemic, food insecurity rose, and certainly disproportionately in Blacks and Hispanics. You can see here that during the course of the COVID-19 pandemic, levels of food insecurity were reported to be extremely high in these groups. We know that the pandemic has exacerbated feelings of loneliness. In one survey, 23% of people surveyed felt left out or forgotten before the pandemic, and that number increased to 40% after the pandemic. Similarly, 7% felt isolated before the pandemic, but 61% felt so after the pandemic started. 25% felt they lacked companionship, and that jumped to 42% after the COVID-19 pandemic. So there has been tremendous impacts of isolation and food insecurity as a result of this. And on top of all of that, the programs have closed. So senior centers remain, they're providing virtual operations and they are checking in virtually, some often delivering a meal, dropping off, doing doorstep drop-offs for meals. But really, we know from research that congregate meals like those offered at senior centers or churches where people can share a meal, enjoy time together, and engage with others are truly appreciated. And our communities have seen these types of meals dwindle. So we know that some services like Meals on Wheels have reduced their deliveries to frozen meal packs in some areas as a result of the pandemic. And many adult day programs, which is obviously my space, have been forced to either operate remotely, close temporarily, and many have closed permanently, which is going to leave a critical gap in services for some people after the pandemic is over. So we cannot really address nutritional risk unless we promote social isolation. We need to foster social support, networking, and community involvement to help protect older adults from food insecurity and reduce their risk of physical and mental illness. Those food security interventions that include some degree of social interaction are really likely to be the most effective, strengthening the case for congregate services and making sure that the services in our senior centers are robust and reopen swiftly once this population has been vaccinated. We all have a role to advocate for these services because they're critical. We know it's not just enough to do a doorstep drop-off. Older adults need more than that. For their health and welfare, particularly to minimize their nutritional risk. So with that, I'd say thank you for your attention, and I turn the floor over to you, Dr. Torres.
Wow, this was pretty also substantial in terms of feedback. Very much thank you, Dr. Sadarangani. Now we have Dr. Szanton, who is going to be presenting her slides.
Thank you so much. Thanks for the opportunity to be here with you, and what a great panel to be part of. And the nutritional screening is dear to my heart because in the first visit of the Capable program that I'm going to be talking with the nurse, the very first thing they do is they say, tell me about a typical day in terms of food. And we don't do it in terms of like, are you only having, junk food? It's really more understanding their social milieu and just they have a daughter who brings them food, or can they reach things, or, all of those social interactions around food. And of course we care what they're eating as well, but we really are aligned in terms of that. I also just wanted to say in terms of a segue that, as you pointed out, but I think it's really stark, that people who are food insecure have the disability status of people 14 years older than them if they're older adults. So if you're a 70-year-old who's food insecure, you have the same functional limitations as someone who's 84. So this is really really under-recognized and really important. I appreciate your work so much. So I wanted to just start talking about the seminar is about health disparities. People use disparities, equity, equality, and I just wanted, this is a from the Robert Wood Johnson Foundation, but disparities I think sometimes is more about documenting the differences and problems, and I think equity is more where we should be going in terms of making sure that the outcomes have equity to them, and that it's important not just to think about giving the same thing to each person. Like in this top part, people are getting the same bicycle, and you can see it doesn't fit for three of the four people. But if you give a tailored strategy to trying to promote, then everyone on this bottom rung can move. So I wanted to kind of start with that in terms of framing, and then my background, I'm a nurse practitioner with a research degree, PhD, and done a lot of house calls in Baltimore. And in terms of health equity, one of the very, very important things that's often overlooked in terms of the medical systems and health systems is people's disability, their ability to bathe, to dress, to walk across a small room, to be able to do meaningful things like Tina was talking about in terms of eating with other people, preparing food for a grandchild, being able to get out to go somewhere with their grown child. And until Capable came along, most interventions addressed the person or the environment, like with grab bars or something. But Capable does both at once to try to improve the fit between a person and their environment. Interventions that happen at home, or I would widen, given the audience, at adult day centers or senior centers, but not in hospitals, not in clinics. Interventions that happen in the community can be a real key to equity because they flatten the power structure. And you're not trying to dress up to be a certain way for a doctor in a hospital that is easy to get lost in. You're going to your regular daily place, and you're used to you're comfortable with the people around you. It's easier to tailor interventions to people out in the community and to address social determinants like social isolation or food access. It's also easier to involve family when you work in the community, and family, that no one is an island, and unfortunately some people end up being islands, but the more that we can incorporate family in what we do, the more long-lasting will be. So just going back to function, function is really important in terms of overall healthcare expenditures from the society. So this is old data, but the shape is the same. You can see that focusing on chronic conditions, where my arrow is, like having asthma or high blood pressure, is important, but where people become what economists call big healthcare spender, more likely to be in the hospital or nursing home, is when those chronic conditions start causing issues with activities of daily living, like bathing or getting food in the house or managing their medications. And so it's all important. It's important to address everything along this pipeline, but function has really been ignored. And I'll just briefly tell you a little bit about Capable, which we developed based on my house calls experience and also adapted it from the ABLE program that Dr. Laura Gitlin developed. So Capable is 4 months long. As I mentioned, it addresses the person and the environment. That's with an occupational therapist, a nurse, and a handy worker. And the whole thing costs a little less than $3,000. A little less than half of that is the budget for the home, and that could be repairs, you know, if there are floors that are unstable, or modifications like grab bars, or even handy items like a crock pot if someone doesn't have teeth, or a pull chain for a ceiling fan. And the main outcome, the main thing, it impacts all kinds of things like falls and depression and pain, but the kind of the money side is that it impacts activities of daily living. And one of the really important parts about it is that the older adult is the expert. That is our view, that it's about them being able to age at home. And so we aren't the experts. The nurse isn't the expert. The occupational therapist isn't the expert. The older adult is expert in what matters to them. And this is part of what I've been trying to say about equity is we can't come in, as Tara was saying, we can't come in and saying, here's what you need to know. That it's the people themselves who are aging who will tell us what matters to them. And so then as clinicians, I believe it's our role to support what the older adult wants rather than to come barreling in and saying, this is what you have to know about all your conditions, or right. So, and even though it's very non-medical, we've shown that we can save medical costs 7 to 1, so that it capable costs about $3,000 and it saves more than $21,000 per person. And so I'm not sure how many in the calls are nurses or other clinicians. This focuses a little bit more on the OT part, and the handyman part, but I just wanted to quickly illustrate. So this was and the older adults set their goals. So in Mrs. R, she wanted to prepare meals more easily without shortness of breath, and her back hurt when she did. And so the handy worker lowered her cabinets, and we put a mirror over the stove, which you can see angled down so she can sit down and still see what's in it, really small things, and a reacher so that she can reach items. And you can see these are tiny things. We end up doing about 14 things for each house for that $1,300 budget. But the way it works is because she said she wanted to be able to cook better. And she didn't have to have the ideas about the mirror, and so that's brainstorming with the occupational therapist. This is just an obvious example, but you'd be surprised how much substandard housing there is that could be fixed by a banister. Costs about $85 to buy and install, and you can imagine that's probably saved a hospitalization right there. We have 25 published papers. I'll just highlight 2 quickly. This one was in Health Affairs, showing on the left that about 75% of people improve on their activity of daily living limitations, and the average improvement is cutting in half. So they come into the program with about 4 on an average, like it's difficult to bathe, to dress, to groom, and to get up and off the toilet, and they end with about 2 difficulties. And you can see the IADLs, the majority improve as well. And this was from another study, a randomized controlled trial, showing the decrease in ADLs as well. And that was compared to a control group that had as much attention at home, but sedentary attention. This was what I mentioned, that the government evaluators showed that it saved about a little more than $20,000 a person. Whoops. And that's to Medicare, and there's an additional saving to Medicaid. And the way this works is that this is per quarter per patient, so times 8 quarters, because it's 2 years, makes that $22,000 number. And then this was a different study, same cohort, but this was the Medicaid savings, and you can see the difference is in this orange area is the biggest difference, and that's in hospitalizations. And the dark blue area, that's nursing home admissions, and that difference is enough. That difference that's about like that size is enough to pay for that whole rest of that 300-person cohort. So function is an avenue for health equity. It's costless, and so that means that as a society we can invest in money. It's what all of us care about, right? We want to be able to see our friends and do things and go places and function as a grandmother or a child or a teacher. And it's virtually ignored except for after something bad has happened, after someone's broken a hip, after they've had a valve replacement. And so we really argue that a way for equity forward is to preventively intervene on function in ways that are important to older adults. And we've shown it can be modified. I just want to end with giving a plug for Heather McGee's book called The Sum of Us, and about what racism costs everyone and how we can prosper together. And her argument is that most structures have racism undergirding them. You know, if you think about redline, the housing system, the health system, job safety, Social Security, and that if we attack them, it benefits everyone. And her central metaphor is you see this young man jumping into a pool, that when it was required that swimming pools be integrated, a lot of communities put concrete in them and filled them up and made it so that nobody could swim, which is just kind of shocking. But we've really done that in a lot of ways, like with the housing recession, started off 10 years before in terms of lenders doing terrible things with Black and brown lenders, and then figured out how to do it, and then did it to the whole rest of the country. And if we had noticed and cared earlier enough, it would have saved all of us. And so I just really urge people to read that book. So thank you.
Thank you, Dr. Szanton. A lot of food for thought with our panelists here with us today. I see that we've been a little busy on the Q&A, and let me start with the first question. What metric did you use to identify senior inactivity levels? Example, 30 minutes walking, 3 sessions a week, and I believe this may be geared towards Dr. Cortes.
I think that is back to me. We basically we use very subjective measurements. It was one's perception of how much more that they were actually doing more activity. In our next study, we will be very much more. We will have definitive metrics for all of our activities that we will be measuring. But this was a pilot study, so we were just trying to get a feeling of what we were doing at across all of those various topics.
And the next question from Kathy, also for Dr. Cortes. Did you have qualifications for your volunteer corps? Who comprised the volunteers?
One of, my wish when we started this was that we have all older people, because again, I feel you need to hear from people who are like you, who look like you, who talk like you, who are like you. And we found that as we moved forward and we had these younger people, we also saw the value of intergenerational teaching, that we would be teaching then the younger how to interact with the older and understand more what the values are of the older people. So we added the intergenerational piece to it. And I think, in retrospect, that was the right way to go. It's good to have people from different age groups interacting. So the only real requirement was a passion to do this, the desire to do it. We did need to have some Spanish speaking people, because many of our participants in the Bronx were Spanish only speaking. So we did have, that was a requirement for us. So we knew we needed to get some Spanish speaking. But other than that, it was anyone who could qualify, but they were trained, and then they had to pass a post test with 80% of the knowledge that was in that test, because we wanted to be sure they knew the knowledge to go out. And then very often we sent someone with them the first time, another trained volunteer, to help them and be sure that they were doing it the right way.
I see that there's Jennifer posed a question. There was a mention of social isolation as a future area. Would you talk about social isolation a little bit? Thoughts on how mental health needs may need to be addressed when addressing social isolation?
Actually, in a proposal we're writing right now, we're going to be addressing social isolation and build into that program signs and symptoms of depression. So that if people who have been socially isolated are experiencing depression, we then will have them, we will ask anyone who feels they're depressed based on what we've given them, they would take a screening, and then we could move them into resources and services to address the depression. We think depression and loneliness and depression, it's like what's the cart before the horse or after? which comes first, but depression is something that is treatable, and we would like to get people into appropriate support services for it.
Great. Adam is asking, if you are addressing lonely, socially isolated individuals, what do you do to overcome loneliness-driven behaviors, since these behaviors often prevent people from trying new things?
You know, I can start on this, but I think probably both Sarah and Tina have input too. I think that certainly social isolation drives loneliness. We know this, and especially over the last year, we've seen a lot of work done. A lot of work has been done on social isolation and loneliness. And I think involving people, I mean, nursing homes became very creative in using technology to engage people through games or through, certainly through visits with their families and friends. So I think technology has a big place in our future. And I think we're just beginning to touch the tip of the iceberg because we were forced to do so through COVID-19. And Tina and Sarah, please add in.
Great. Now we got, go ahead, Lisa.
Well, I'll just say, I'm thinking that we've done capable with people who, on dialysis, and we've learned through focus groups that people told us that they felt especially isolated from their family with dialysis. That so we modified capable a little bit to try to really stress what do they want from social contact. And it was so interesting. Like, for example, one of the people's main goals was to be more intimate with her husband. And she specifically said she was not talking about sex. She wanted to be able to do things that felt intimate together. And they came up with a plan to cook together. And part of what we got for the house was implements to help them cook together. And by the end of the time, she felt like she had really, they both felt like they had really achieved that goal. So I do think that I agree with Tara, there's a ton that technology can do, but I think also really understanding what people want and what social isolation means to them and what relationships they want to try to bolster is key.
Dr. Sadarangani?
Yeah, I just wanted to add, I think part of it is also in terms of trying to help them overcome these behaviors is really making it a part of our assessment. We've learned in this pandemic, clinicians, nurses, doctors, they're really trusted individuals, and addressing loneliness as part of that and offering up these interventions, these ideas is really important part of the dialogue. Being lonely is just as bad for your health as you're smoking cigarettes, right? Worse, if not. And so I think if we're going to address those things in a visit, we need to screen for this, address this, and come from the best of intentions to say, here's a recommendation for you, here's an intervention for you. Unfortunately, I think one of the biggest problems we face and barriers to that is that as clinicians and providers in primary care, we don't have a good knowledge base of the programs and supports that are available to older adults. And so recognition of that, learning more about that, and prescribing them just as you would prescribe a medication is really important.
Samuel has a good question here as well, comment on a question. I'm a graduate student pursuing my master's in nursing with 4 quarters left to becoming a family nurse practitioner. I was lucky to write a discussion board and discuss in class the topic of competent care. Discussing the concept of competent care availed me to the ability to understand how this could impact culturally centered quality healthcare outcomes and disparities. I wish to ask, do you think we should advocate for training demographically specific professionals and, most important, culturally specific practitioners to serve in these culturally specific health deserts? Case in point, we saw how this was true in the case of COVID-19. A Black physician took to the streets of Philadelphia to convince Black individuals to embrace the COVID vaccines. Since the Black physician became a competent healthcare advocate, I ask this because I believe there is a trust issue here for various obvious reasons, where folks will pay attention to their health once they trust the individual professing.
Okay, I think, this reminds me, Sarah, of your first slide, the equity and equitable, and I'd love to hear your answer on this.
Well, I think trust is at the basis of any relationship, and I think that having a diverse workforce is really important, and I agree that deploying it carefully is really important, but I also think that white people should be more trustworthy than we are, and it shouldn't be only on minority providers to be trustworthy.
I also want to add to that, if you don't, that we need to, it's not just our physicians, it's not just our nurses. We need, diversity in our programs, in our offerings. We need to recognize that, in the immediate term, that with what's in front of us, that maybe we're kind of over relying on people who identify as true healthcare providers versus not recognizing some of the powers and values that our community-based programs have to offer. So I always like to point out that the senior centers, the adult day programs, they have staff most often who are, these centers are microcosms of their communities, their neighborhoods within neighborhoods, their communities within communities, and they often represent the people that they are serving better than our overall healthcare system. And so strengthening those programs, better resourcing them, and recognizing what they do for their participants in the form of culturally and linguistically congruent care is very important in the immediate term.
And I would agree with you. And I think we've seen some of this through the vaccine hesitancy rollout and the use of communities in helping people to understand why the vaccine is important. I often say, the minority community isn't going to understand when I stand up there and say it, but when they hear it from their pastor, they hear it from their church, their places of worship, they hear it from their colleagues, their friends, it makes a difference. And Anderson, you must have had experience with this, particularly in the Bronx.
Well, we have actually, but that's why these campaigns where you have trusted community partners representing places of worship or representing cultural alignments go a long way in helping individuals understand that, this is the right thing to do. People ask, and they asked me, how did it go? I said, I got vaccinated. I had one side effect. I just started walking backwards. So, just using also humor and having cultural relevancy is key to the rollout, and educating people. Mind you, not all older adults, example, have access to a tablet, have access to a smartphone, and looking at which sites are offering appointments and registration and so forth. So we had to, as an organization, take a very proactive approach in educating and signing individuals up. In one campaign, we had over 300 individuals that our staff had to call about 3 times to just confirm the appointments. And that's just the tip of the iceberg. There's another segment, and Dr. Cortes, I had mentioned Monsignor Szanton, who's on the conference here, and he was advocating, what about the homebound? Where are the vaccines for that population and their level of trust and distrust in people coming into their home and neighborhood? So it's a pretty involved process, and cultural humility needs to play a role.
Mm-hmm.
I have here a comment from Robin. Wonderful programs, but having witnessed the horrors of our failed system during the pandemic, it seems as long as hospitals and nursing homes are profit-making businesses with patients being nothing more than a commodity, can you understand that I see this as too idealistic? Who would like to take that one on?
I will just, go ahead, Tim.
No, I see Sarah was about to say something, and
yeah.
Tina?
I will just say that certainly it's hard not to hold that view. That view is a very valid one, particularly in light of what's taken place. That said, people need advocates, programs need advocates. We can't do away with hospitals and nursing homes. They're not going away. We need to strengthen them. We need to improve them. There's no doubt about that. But I think we need to recognize and continue to use some of these other resources. We need to be diverting some of the resources from those things to some of these community programs. Communities, I think one takeaway from this pandemic, communities are the front lines. We've been talking about the hospitals as being the front lines. They were the front lines when it was too late, when the community when the communities were not well resourced, when there wasn't enough community prevention, that's when we go to the hospitals. And so really trying to reimagine our healthcare, diverting and changing how we give resources, especially with respect to long-term care and older adults, to more community-based sites is much needed as part of a larger program of advocacy for these patients so that they aren't commodities, but they're people with needs.
Yeah, and I would add to that then, I think it's so important then for people to really be working with their legislation, both in the state and at the federal level, as well as advocating for policies that help us to transform the long-term healthcare system into a meaningful one for our future populations.
I think we have room for one more question, and here's one that I think we can all relate to. What are some strategies you recommend to overcome the mistrust among racial groups? I know, Dr. Cortes, you had commented on that as well. I mean, I think as we all comment on this, it is very important to understand who your community leaders and trusted individuals are and ask the community themselves, who do you trust? Who can we go to? And people will tell you.
I would agree with you, and I do want to hear Sarah's opinion on this, because her the last statement she made on the filling up of the swimming pools and the red zoning and all of this, it's the structural imbalance that has created so much of this. And I think until we admit that it actually exists, that there is such a thing as social injustice, and there's structural racism, because a lot of people don't believe there is. And I think it's something that we have to understand and believe it. Sarah, do you want to take that up?
No, I think both of you, spoke my mind. I think that I will just finish by saying that it's really important that Black and brown people lead, but this can't be just a problem for some people, that all of us have to be all in on making us be trustworthy, and we can't just have it be like, this is somebody's problem. It's our whole country's problem. It's been the defining problem since the beginning of the country. And hopefully we will take this very difficult time to change finally.
Okay. Dr. Sadarangani?
I can only echo those sentiments. It's absolutely underscores everything we do as clinicians. So, it has to be at the forefront and the focus of our work. It has to be ingrained in what we do.
Well, I can't believe that an hour has already passed. I want to take this opportunity to thank my dear friend and respected colleague, Dr. Tara Cortes, Executive Director of the Hartford Institute for Geriatric Nursing and Professor at NYU Rory Meyers College of Nursing, and our distinguished panelists for taking the time to join us today and talk about such an important topic, not forgetting our older adults, the ones that have walked the walk, and should we be so lucky to do the same as we age in place and in our communities.
Thank you.
Thank you very much. Bye.
Thank you.